Well, good morning. Good morning, everybody. I would like to bring this session to a beginning and to welcome you all to this second session this morning from the Radiology Leadership Institute. I don't know how many of you were here at the last session, but you were treated to an absolutely excellent set of conversations around leadership challenges, and it was, I think, an opportunity for a lot of insights. I think that you're going to find this session similarly offering opportunities for insight in that it's really a privilege for me to moderate 5 of our practice leaders who have all experienced substantial change in their environments and their practices, and so that's what we're going to be here to discuss. I should first mention my name is Jeff Rubin. I'm from Duke University, and in just a moment I will introduce our panelists and give you a sense of the structure of what we're going to be doing here this morning. The session that we're presenting to you is a session that evolved out of the Radiology Leadership Institute Summit that occurred last August at Babson College, and each of these individuals presented such tremendously compelling stories that we wanted to offer it and bring it forward to you as well. So the way that we're going to be structuring the presentation is that I'm going to give a bit of a introduction around strategy from a formalized sense, from a framework sense, and then we can see where the real world hits on the ideal themes. Let me take this moment, though, to introduce the panelists to you, and that way you'll know who you're hearing from. And we'll just sort of go right down the line here. So first to my right is Michael Webb. Mike is a practicing interventional radiologist and the president of Mountain Medical Physician Specialists, which are based in Salt Lake City, Utah. He serves on the board of managers for strategic radiology and previously served as a medical director of imaging for Intermountain Healthcare. Next to Mike is Samir Patel. And Samir is a radiologist with Radiology Incorporated in North Central Indiana. He is a member of the Elkhart General Hospital Board of Directors. He is also the founder and director of Radiology Inc.'s Value Management Program and has done a lot of tremendous work around establishing methods for bringing quality into radiology and developing Imaging 3.0 stories. I should also mention that he has black belt certification in lean healthcare. Next to Dr. Patel is Chad Callandine. Chad is from Nashville, Tennessee. Chad is the president of Premier Radiology, which is an imaging center company joint ventured with St. Thomas Health, which is a division of Ascension Health. He is also the CEO of Advanced Diagnostic Imaging, which is a professional group of over 40 radiologists covering 5 hospitals and over 100 teleradiology sites. And he is the CEO of Phi Data, which is a billing and management company. Next to Chad, we have Syed Zaidi, and Dr. Zaidi is the president of Radiology Associates of Canton and chief executive officer of RadHelp. He has been a nationally recognized innovator in radiology co-management services and radiology population management services and strategies as well. And then last but certainly not least is Jonathan Breslau. Jonathan is the Chief of Imaging at Sutter Medical Group and Imaging Service Line Medical Director at Sutter Health Valley area in Sacramento, California. So you can see that we have a panel of folks that represent a broad spectrum of leadership roles in community practice from various parts of the country, and it's really a privilege to be here working with them. So I'm just going to go ahead here, do the slides. And so I've already told you who I am, and I'm going to talk about a little bit about anticipating the future through strategic planning. I have nothing to disclose. Here is how things are going to be organized. After I speak for about 10 minutes or so, we're going to divide the stories that are going to be told into three components. The tales of tumult in American radiology, which ultimately relate to recognizing that there is a problem. And that's the very first step before being able to fix it. And so each of these leaders will speak in turn about the problems that they faced and how it was recognized. Then we're going to talk about the power of planning, which in a sense is the notion of analyzing the problem and strategizing to solve the problem. And then finally, motivating migration, overcoming inertia to a brighter future, which is effectively executing change. And so each of these leaders will take 5 minutes in each of these three domains to tell their story. So first off, recognizing a problem. So the ability to recognize that things are not going well in your practice requires that you have an organizational structure that is set up to recognize that problems exist and to bring them forward and in a transparent fashion. And this requires that you have a collaborative and diverse team, that all inputs can come to the table and bring ideas forward. This cartoon says, we fired all the troublemakers 6 months ago, around the time this company generated its last original idea. Sometimes the folks who seem to be discontent, or the folks who have issues that they're consistently bringing up, have very important inputs. And while it can be challenging at first to accept having them in the room at times, it's important to have them in the room and to not ignore anyone's voice, regardless of where it's coming from. Within the context of an organizational structure, building into the organization, even within the context of very busy radiology practices, regular meetings, whether they're on a quarterly basis, a monthly basis, that is specifically focused on asking, how are we doing? What are the issues? Not necessarily scheduling every agenda item to address the minutia of the day, the minutia of the practice. A free-flowing discussion should be encouraged and with some sense of a future focus. And it is also important at this stage to have relevant inputs to the discussion, to identify what is truly an important issue and to have metrics available as well. And so within the context of developing an effective organizational structure, one that is attentive to the business, to the quality, to the various elements of the service that's being delivered, to having metrics available, to establish the effectiveness of how the group is doing, and to recognize when things are trending in the wrong direction. If there are no data, then it becomes sometimes an exercise in perception and an exercise in he said, she said. The next step that we'll talk about is analyzing and strategizing. And we could spend a day talking about all the tools that are out there to analyze a firm, to analyze a practice, and establish strategy around what that is. I'm just going to briefly mention two of them, which I think are particularly useful and which I have used in several different organizations. The first one is SWOT analysis, and the next one is value chain analysis. So let's start with SWOT. Let's start with value chain, and then we'll do SWOT. This slide here represents two elements of the generic radiology and imaging value chain. Let's start on the bottom here. I mean, in a broad sense, when we think about the imaging industry, we begin from the standpoint of people who supply equipment and parts for the creation of the devices that we use to image patients, which then provide them to radiology departments, which use that equipment to produce images, to produce interpretations, and to communicate important findings and to deliver care. From there, the information flows to clinicians that are directing the patient care, and then ultimately that flows to the patients and the payers, with the chief outcome of this whole value chain is health improvement. It's important to understand where you stand within your own local imaging value chain. And what I mean by that is understand who are your suppliers, where are your patients coming from, and understand where they're going, who is using the information that you're providing, and never lose sight at the end of the value chain, because that's where the value is being delivered. And it's important to constantly ask yourself, am I providing the right value, and is it being translated through that value chain? Within the context of your own practice and your own environment, then, is the portion up at the top. And this is breaking out the value chain of the practice. And you can see that there's two components. There's primary activities in the bottom half, support activities at the top. If you look at primary activities, and again, I'm describing these in a generic sense, okay, scheduling and protocol preparation, image acquisition, image processing, interpretation, report and communication. You should be working with your team to look at each of these silos and ask, how are we doing? And to even, potentially color code these in a way that highlight areas where you are just killing it and areas where there's challenges, to highlight the areas that really need to have focus and where your risks might be. And even though it's very important to focus on all of those primary activities, it's important to recognize that there are support activities that have every bit as much importance to the functioning of your practice as the primary activities. And I've listed some of those there. Your revenue cycle management, your IT, human resource management, hiring and firing and bringing people on board and benefits and all of that, and then just general infrastructure relating to your facilities, maintenance of your equipment, all of these things. If you have a chart like this and you keep looking at it as you have these conversations, it will spark ideas and it will allow you to have a scan on both your environment and on the firm. Now, the other tool I mentioned was SWOT, which stands for strengths, weaknesses, opportunities, and threats. This is, as I mentioned, a very valuable tool. In general, you can think of strengths and weaknesses as being focused on characteristics of us and our practice, and you can think of threats and opportunities of characteristics of the environment in which our practice works. And there are a number of details here that you will want to evaluate. For example, on the threat side, looking at economic conditions, looking at the marketplace in general, roadblocks to progress externally, and potential weaknesses. In the terms of opportunities, similarly, these different characteristics. I'm not going to read every element of the slide here for you. There's lots of material available on the internet or in books around this technique. But again, sitting down and having a review of the SWOT analysis on some regular basis will help you to continue to focus on building your strengths and on addressing your weaknesses. And this is all part of recognizing and analyzing the practice. The next step is strategizing. And once one has identified the sources of weakness and risk, it's asking the question, what are we going to do about it? It's also considering what are potential scenarios down the road. What if reimbursement falls by 5%? Where are we at greater risk? What if an imaging center is built by a competitor provider in this community? How is that going to affect us? Thinking through the most likely scenarios that you might face in your environment can help you to discover hidden risks and to be able to work to mitigate them. Consider the possible interventions that you would undertake should these scenarios come to fruition, and then identify what the risks would be of implementation. Finally, how do you execute change? What are the steps? Change management is the topic, and in fact, Bill Thorworth mentioned this work here by John Cotter, Leading Change. He has a book. There's also this publication, which you can get from Harvard Business Review on change management. It actually has 10 excellent articles on the topic that I have personally found very useful, and I know that others have expressed the value of it as well. I want to highlight to you, though, that I feel that the term change management really misrepresents just what this is about and what is hard about it, because it's really better considered change leadership. This is without a doubt the hardest part of the whole process, is helping people to recognize that the world is going to be different. It begins with an aligned culture that accepts the inevitability of change. And heck, that is just 1.5 lines of probably the hardest thing you can ever achieve. It is it is something that if you work as a leader, if you work as a member of your practice toward achieving over time, then you will set up an environment where when it hits the fan, the folks are ready to deal with it. But this is something that requires constant focus, even in good times. The realities is that change is emotional, it is non-linear, and it cannot be forced. If people are not ready to accept change, they will work to block it in whatever way possible. And so that is why it's important to recognize the fact that you must engage with people at an emotional level to understand the pressures and to help work them through it, and to help people realize that even though we see that brighter future of where we want to go, it's not a straight line. There's going to be steps forward, steps back, there's going to be disruptions, and ultimately, if we work together, we're going to get there. But without accepting and communicating this fact, you'll lose people. And it's very important to be very open and honest about those things. So here's two guys. They only have two demands. Why don't people give them just what they want? You know, I mean, basically, this is one of the challenges. Innovation sounds great, you know, making things better, but as long as it doesn't require us to change. This is Cotters' 8 steps, and I'm not going to go through these for you. I think that they are a great framework to think about implementing change. Again, you can just search Cotters' 8 steps on the internet, and you can spend, you know, a couple of hours reading about this. You can read stories about the challenges of implementing these steps, but it really takes you through the notion of first preparing the environment for change, to create this sense of urgency, to get the right people in the room. This is very, very hard. Anyone who's tried to implement change knows just how difficult it is. And so thinking through what these steps mean for you and how you would implement them is the way to begin to address this. So let me just conclude this opening by saying that, you know, when you think about strategizing for change, the first step is just recognizing the problem and establishing a culture within your department or organization to be prepared to bring problems forward and to recognize they exist. To have tools available to analyze and to strategize how to address, and then subsequently the execution of change. And hopefully, at the end of the day, you're not faced with this. She's walking away, job done, and these two guys are celebrating, quick, let's go back to the old way of doing things. So hopefully the change will be one that sticks, as I say. So with that said, let us, I'm going to actually, I think, just it'd be great to turn the screen off. Maybe I'll just leave our title slide up and do that. But with that, I'd like to begin with Mike Webb. And Mike, help us through the first step of our process here, and describe to us about the challenges that you faced in identifying the problems.
All right. Thanks for attending this morning. I'll preface my comments with don't try this at home. I'm part of a group of 70 physicians practicing in northern Utah. Utah is a relatively small market compared to some of the larger markets, and we practice in a large vertically integrated healthcare system. In our market, we are twice the size of the largest, next largest group, and the system that we serve is substantially larger than any of the other systems. And from that standpoint, our group and that system are somewhat mutually dependent on each other, and I'll emphasize the word somewhat. At the time of our initial problems, there were 9 different radiology groups servicing the system, and those groups ranged in size from, I believe, 2 radiologists to 70 radiologists, so a lot of small radiology groups. And understandably, the system was hoping and wanting to align those groups both with each other and with the system. And they asked the groups to participate in a process of alignment. And our group enthusiastically participated in those discussions. As part of those discussions, and the alignment process. It was hoped that the system would be interested in, and they seemed to be interested in purchasing our imaging centers. There was assurances made that there would be tracks for both groups that would be interested in employment and groups that wanted just to simply be affiliated. Specific public and private assurances were made that this would not turn into, an employment, a forced employment situation. Those talks went on for some period of time, many months, if not a year, and abruptly the system, and without explanation, the system withdrew from those talks, and indeed they did change to an employment-only strategy. We, as a group, were the first, one of the first groups to engage the system in employment discussions, and we did that with an open mind. In short, because our time is short, the employment offer that was made was untenable for us for many reasons. One, Intermountain already had a small cadre of employed physicians, and the terms of employment for us were substantially different than the terms of employment for the currently employed physicians. Compensation was dramatically less. Call responsibilities were completely asymmetric. The other issue was that Intermountain was not at all willing to entertain the idea of allowing group self-governance. They demanded individual contracts, et cetera, et cetera. Perhaps the nail in the untenable coffin was that Intermountain was demanding that we divest of our imaging centers. No one was willing to purchase our imaging centers for fear that Intermountain would disentangle them. Intermountain understood that, and they said, if you cannot get rid of them, you will shut them down. And we had huge investments that were on the line, and not to mention jobs, etc. So many physicians in the community were aware of these discussions. They became public, and the Utah Medical Association was sort of following the discussions from afar. Our group, essentially each individual member of our group, we received a letter with an ultimatum that we would be replaced if we did not acquiesce by a certain date. We had an emergency group meeting, discussed the options, and had a supermajority vote to continue discussions but reject the ultimatum. We conveyed that to Intermountain. Intermountain said, thank you very much, we're done with you, goodbye. We said, well, what does that mean? They said, we'll get back to you. At the time, we didn't have a contract, so we still had staff privileges, and I will leave our story off at that point. But it's not hard to recognize you have a problem.
How about a round of applause for Dr. Webb? Terrific. Excellent. Dr. Patel.
So thank you, Dr. Rubin, for allowing me to present sort of our story. And I am in private practice in North Central Indiana. We have 36 radiologists, and we have been in practice for over 100 years, and since 1904. In fact, the founder of our group actually helped found our largest hospital that we provided services for. So that's, sometimes they say pain is the greatest way to motivate change and teach a lesson. About 4 years ago, there was a disgruntled member in my group and who happened to hold a very high position in the hospital. He was chief of staff and subsequently was on the board of the hospital. And we apologized. We made no apology to him for his terrible lot in life, for the benefits that our group had afforded him. But he started spreading some not so nice things about our group, stating that all we do is we come in, we read films, and he was an interventional radiologist, no disrespect to the interventional radiologist. I'm not a lumper, I'm a splitter, so. But he had a platform, and he had a platform to say some things, and our group really didn't have a strategy. And so what had happened was he wanted to section off a certain part of the group to become hospital employment because he was already quite happy with his arrangement as far as having the respect of the hospital. And so what happened about 4 years ago, the hospital that our group helped found almost 100 years ago said, I think I've heard from the medical staff, this is the CEO of the hospital, that we're not quite sure the value that you bring to our enterprise. And I think we're strongly considering moving in a different direction. The thing that I hope to share is if 100 years of sweat equity and respect does not afford you anything, be warned. And that is unfortunately the pain that our group sort of had. And we were very close to losing the contract, partly because of a disgruntled physician, but partly because of a perception that we had no strategy. We were not a low-cost provider. We were not highly engaged in research. We had no strategy. We were doing all this stuff, and it fell on deaf ears when we used to say, oh yeah, we bring a lot of value to the table. Can you prove it? Well, we're just radiology. We bring a lot of value to the table. That didn't go very far. And again, 100 years did not give us any benefit. So we were very close to losing our largest hospital contract. And obviously in our area, where it's not a big city, it has severe ramifications for radiologists and their families, because if we would have lost that contract, I would have had to move, uproot the family, and go somewhere else. We don't have multiple systems that I can choose from. So that was sort of the chilling tale, is we did not have a strategy, we did not demonstrate our value, and we relied on our laurels of 100 years and the fact that we're radiology, we're important. It was a very problematic between the perception and the reality. The reality was we were doing a lot of stuff. Also the reality was we were not very good at telling that story and how that impacted the healthcare system and how valuable we were in the healthcare system. We did a terrible job. In fact, we did no job in doing that. And so those were the two things we had to fight and this was we had to do this very quickly because we were close to 60, 90 days out. And so I will leave my story right there. But pain is unfortunately sometimes the greatest motivator.
Thank you. Thank you, Dr. Patel. Dr. Calendines.
Yeah, well, thank you for being here this morning. My story is not nearly as exciting as Mike's story, but we were in a situation that probably a number of you have been in. We were a 40-person radiology group. We're in Nashville, Tennessee. We'd grown the practice nicely. We had 3 hospitals were with the St. Thomas division of Ascension. We had 2 other hospitals. We had a joint venture that we just started with St. Thomas where we had 9 imaging centers that were growing. And we had a teleradiology practice. The group had done teleradiology since the 90s. And so we felt relatively well diversified. But strategy is not about addressing immediate problems, but rather having a growth strategy and understanding the vulnerabilities that your practice has. And so I think we were very introspective at the time, and we really saw that we faced 3 significant problems. One was leverage with the hospitals, and this is what is suffered by radiology groups everywhere. We are seen as oftentimes a contracted service. Sometimes we're a pain. If we're not a pain, then that's doing pretty good. We don't do a good job about explaining value. And 5 years prior to that, the group had lost a significant hospital contract, and that has stuck with us. In fact, it happened a week after I became president of the group, so it's really stuck with me. And I operate in this PTSD version of management. And so having leverage with the hospitals, what I think is clear is the only way to have the leverage that we want with the hospitals is if we have what they value, and that is admissions and surgeries. So we understood a vulnerability there that is suffered by most. There was a changing payment landscape, as we all know, and it's going to accelerate in the coming years. And again, focused on strategy is not what we're missing today, but how are we preparing for the future? We had a number of the large groups in Nashville, of which we were included, developing different risk-based strategies, some of it around Medicare Advantage plans, other around risk-based models, most of it directed by primary care. And again, where they saw radiology was a contracted service. and a contracted service that they want to pay less and less for. So another significant vulnerability, and as Medicare continues and the private payers continue, that will become a bigger problem for all the groups here. And then in a more granular way, we had a significant investment in outpatient imaging, and we saw that the other health systems, we were partnered with St. Thomas, but in Nashville, there's also a large HCA presence, and then there's Vanderbilt, and all three systems were employing a lot of the referral sources, the clinicians. And so to the extent that Vanderbilt and HCA outpaced St. Thomas on the physicians that they hired, we had significant vulnerabilities to see our referral sources to our imaging centers be employed by another system and walk away. So that's where we saw our vulnerabilities, and that's where I'll leave the story.
Excellent. Thank you. Dr. Zaidi.
Thank you to Dr. Rubin, and I'm honored to be on this esteemed panel sitting shoulder to shoulder with my colleagues here. So my story is that I joined a group, Radiology Associates of Canton, 24-member group. I joined them in 2007, and we were a long-standing group, about 40 years. And Canton, physically, it's important to understand, is about 1 hour south of Cleveland. So Cleveland is sort of the highest in the hierarchy in Northeast Ohio. Then half an hour down is Akron, and half an hour down is Canton. And costs of care also follow that pattern. That's important to understand. And the other things to understand is that there was significant hospital consolidation starting to happen. There was also a erosion of the population base. Northeast Ohio has been hit, like other parts of the Rust Belt, manufacturing, especially in Youngstown. Not as bad as Detroit, but still there has been stagnation of the population. I think some of those effects are finally being seen by the rest of the country in the politics that's happening in that part. So, the hospitals were basically having to compete with each other, cannibalization of patients. They weren't growing, probably too many hospitals, at least too many hospital beds for that area. There are some other radiologists in the room who can testify to, what effect that has on physicians, right? That hospitals have been employing a lot of the physicians, cardiologists got employed around 2009, 2010. By the time 2010 came along, and that's sort of where our story starts, is that our group was doing well in some ways and not doing well in other ways. So what were our strengths? We were a long-standing group, like Samir said, long history with the hospital and the referring physicians. We had 4 hospital contracts. We weren't relying on just one hospital, but our main hospital was 60% of our business. Other strengths, we had 24/7 night hawk and internal service. We never outsourced our night hawk. And for a 24-person group to do that, it is somewhat difficult. We were borderline for that size. Fairly well subspecialized for our size. We had significant IR services. So we had all these strengths. We also had a residency, which was interesting and important as a recruiting tool. But we had a lot of weaknesses. Mom and pop group type of governance. All the partners used to nitpick on every single little issue. And I didn't have a business background, but I think a lot of us had common sense, So within a couple of years of joining, me and a lot of the other younger people were saying, there's a lot of disparity in productivity. There's disparity in how we deal with physician behavior. We're letting people get away with all kinds of stuff. I think very typical for a lot of private practice. Lack of unity on going after hospital contracts. There was a hospital 1 hour away that's been calling us for 5 years wanting basic IR services on a limited basis, and we're not stepping up as physician leaders in the community to go and provide those services. We're letting telerad groups come in and take over services and provide substandard services just because someone doesn't want to drive an hour I mean, I grew up in New York. It used to, commute an hour and 15 minutes on the subway. I know it's the Midwest. People don't want to drive. Even going from Canton to Akron or Cleveland seems like a big deal, but physician leaders should step up in the community. I think we have that responsibility. So governance was a big part of it. Our relationship with the hospital was okay, I would say, but we were treated like a contracted group. Like Chad was saying, we wanted to evolve beyond that. And our contract was coming up for renewal. Our income was down. The contract was coming up for renewal. There was significant competition from Telerad groups, unnamed groups, but 4 Telerad groups operating in our area very actively. So even though we did not quite have an ultimatum from the hospital as much as what Samir and Mike were talking about, we did have some significant threats, and it was time to be proactive and make sure that the next contract was going to be secure, and we had to fix our own governance issues as well. Thank you.
Terrific. And finally, but certainly not least, Jonathan Breslau. Dr. Breslau.
Thank you very much. Pleasure to be invited and to speak. And someday I will measure up to these other gentlemen on the panel. I'd like to just start with our practice situation in Sacramento. Sacramento metropolitan area is about 2 million people, and we had a practice, the diagnostic imaging and radiation oncology, that had been around since 1917, very subspecialized. We did hospital contracts with Sutter, all the Sutter hospitals. And the first thing I'm going to do is skip to the tumult and then go back a little. In October of 2009, we were given 6 months notice that our hospital contracts weren't going to be renewed, and they were going to start building their own radiology group. So that's the tumult that came about quite suddenly. And in terms of recognizing a problem, I would point to a couple things, some of which have been touched upon. First of all, governance. We had 60 partners, and the board was 60 people. And you all can let your minds run wild what that must be like. And we had sort of grown immensely during a period of time when growth was easy, and we believed that we did it because of our genius, not because we were investors in a bull market. Our capital structure was an unrecognized problem, which is the contract by which you buy and sell ownership in the company, which is obviously just a partner, was very structured to only function properly in a bull market, where the valuation is going up. And at the moment, no one had ever thought about this, ever. But as we started to understand what happened when we were going to be out of the Sutter hospitals, which, by the way, was initially only 10% of our revenue. So initially, we had time to think about it. Anyway, we realized that as if the value is going down, the contractual relationships between the doctors was ill-fitting to deal with this in a way that didn't involve machetes. And then finally, the most important, I think, is it really caused us to reevaluate our connection with the hospital and really what does alignment mean. I think it was clearly not an issue of telling them about value. It was understanding how they define value and working with them to deliver their version of value. And we were pretty bad at that. First of all, we thought we were smart and they were stupid, which actually way back probably was true, but it wasn't true anymore. And it sounds funny, but that's a serious shortcoming on the part of, for us, I'm not going to generalize, but that was a shortcoming for us, big time. We kind of picked and choose where the location of services. So if it was something that we liked to do with the outpatient, we would move them all into the outpatient. If it was something that took up a lot of time and reimbursed poorly, we would move that all to the hospital. And the hospital absolutely viewed us as a competitor, and they wouldn't even involve us in strategic planning. And so we thought that we had this sense that we were irreplaceable, but it led us to ignore all these kind of granular things that were falling far short of what the hospital needed in an imaging partner. And when you think about it, to disrupt the whole hospital system imaging provider, subspecialized, been there for a long time, to throw it out and get something new, that's not their first choice either. It takes some time, so we realized that we really had mismanaged the relationship in a way really that was our responsibility to manage.
Great. How about a round of applause for all 5 speakers on this? So the plan is that as we go through these 3 steps, you'll hear the complete story and where it went, and then we'll have ample time for discussion. So that's where we'll bring the discussion. But, I guess if I might just provide a little bit of observation. I mean, clearly, one of the fundamental issues related to everybody's challenges came down to alignment with respect to, and expectations with respect to a hospital and with respect to the dominant healthcare delivery system in which the practices were operating. And it sounds like some of you were better positioned to recognize up front and to perhaps make changes. Others were blindsided. And, whether or not that's a reflection of inherent characteristics of the organizations or a certain level of luck as to when things occurred, it could happen either way. And, maybe if I might just make one brief editorial point, and that is that oftentimes when we look at challenging events for leaders or for organizations, there's a tendency to put, the blame on and the focus on the leader. Things went bad under your watch. But there's an important phenomenon that's described in social psychology, which is called the fundamental attribution error. And that's the tendency to want to blame problems on somebody. But oftentimes it's the environment, it's the system. It doesn't necessarily imply that the leader doesn't have some culpability and some responsibility. But if one fails to recognize the environmental conditions and to accommodate to them, then it's unlikely to solve the problem, and the next leader is likely to have major problems and potentially fail as a result. So in this particular circumstance, clearly there's a consistency of environmental challenges to be seen and to be recognized. And just thinking about the incredible situation where for essentially 100 years, as it was described, a bull market, and then suddenly what happens when that market contracts? How do we respond? Are we even set up for it? So let's move on then to the next phase of the conversation and talk about once you recognize the problem, how did you organize and strategize to address it, and how did you analyze the problem? Dr. Webb?
So we did a rapid old school SWOT analysis. We realized we were a fly on Intermountain's dinner table and we had just been swatted. Our members started receiving, particularly our junior members, and interestingly some of our recruits started receiving recruiting calls for a large vertically integrated healthcare system in the state of Utah. It didn't take very long for us to realize that we were being recruited for our own position. Fortunately, the decision by our group to reject Intermountain's ultimatum was nearly unanimous. And so we started off in, I would say, the crisis portion of the situation relatively united. We had made it clear, we thought, to Intermountain that we were very interested in alignment. So our first step was to try to make contact. We made contact with Intermountain executive and let them know that we thought that their actions were unreasonable, their demands were unreasonable, and that contact was rebuffed, and basically they told us they wanted no further contact with us. So I mentioned the Utah Medical Association had been sort of following from afar. They were now actually involved. We contacted the CEO of the UMA. UMA actually notified executives at the AMA, and legal counsel for both the UMA and the AMA started interacting with our group and our group's legal counsel. We contacted the chair of the Board of Chancellors of the ACR, and the ACR's legal counsel became involved. And I would have to say that organized medicine, for those of you out there who don't have much use for it, was particularly helpful to our group in this time of crisis. We found ourselves just waiting to be replaced, and that's where we found ourselves. Through the attorneys of organized medicine, contact was made with a recently departed attorney from the FTC, and that attorney became involved. And through the Utah Medical Association, I'll also say that other physician groups in the state started contributing funds for some of this legal work, and organized medicine provided this legal advice for no additional cost. So we considered those dues well spent. Long story short, it so happened that the Utah legislature was in session, and two bills were relatively rapidly drafted. These bills were any willing provider bills. That made it to where one bill, you could only impanel physicians on an insurance panel based on their credentials, and the other was that you could only privilege in hospitals providers based on their credentials. All right, and in many markets, hospitals and insurance companies influence things by who gets in, who does not. And so it was threatening to both the insurance market and the hospital market, of which Intermountain is a big player in both. Those bills were rapidly introduced in a bipartisan way. They rapidly went to committee. We found ourselves, myself and one of my colleagues, testifying in support of the bills. On the other side of the aisle were our hospital executives and insurance executives testifying against the bills. The bills passed out of committee. A comment was made. It's distasteful that the bills are here, but if we do not support the bills, then Intermountain wins, and we cannot have that. In short order, and I do mean within 15 minutes, we had a texted copy of a cocktail napkin from the CEO of Intermountain Healthcare saying, "This is crazy, we won't get rid of you if you won't pursue these bills," and we agreed to that strategy. And that was partly at the advice of the organized medicine and that was involved with this. And we weren't looking for conflict with Intermountain Healthcare. So I'm over time, and I'll leave it at that.
Marvelous. We look forward to the next chapter. Dr. Patel, actually, before you start, let me mention that I instructed everybody in advance for a 5-minute time frame to be sure that we got through all of these. And you guys did such a tremendous job the first time in keeping your stories really brief. And I apologize that we don't really have a clock that you can all see. But to the best of your ability, feel free to take the full 5 minutes. It's your time. Dr. Patel.
Thank you, Dr. Rubin. So we laid out the story of back in 2012 that our largest hospital was going to take the contract away. So, and at that same time, there was an affiliate hospital, a smaller hospital, and they were joining together to form a health system. And I was going to be chair of the Department of Radiology. Not that I did some serious lobbying, but typically when in private practice, when somebody asks, gee, who's going to be chair of the radiology department, it's usually who doesn't want to be the chair of the radiology department, and whoever's left over will end up doing that. And so that was sort of my foray into everything, and this is before full implementation of the RLI or anything like that. So here I'm jumping into this position at the same time that they're forming a health system with the other hospital that's going to terminate our contract. So I was a little bit behind the 8 ball. So we did have to give up something. We did have to give up a couple of the IR members and the IR practice at one of the hospitals, but we kept it at the other hospital. But what I told the CEO is in the Department of Radiology, I told him, I said, I see you think that there's a perception problem that radiologists aren't bringing things to the table. Give me 6 months to a year, and I will prove to you of all the stuff that we do, and then you can make up the mind for yourself whether or not you believe that what you've, quote, heard is actually the reality. So what I did was, part of this time, as many people in the group, there's some people that look at work RVUs, some people that don't look at work RVUs, and there's some people that don't have a platform to demonstrate of all the extra stuff, so-called, that they do. You know, most of the time it's typically no picnic to go to a conference if one deems that that's not of value or anything, or to a hospital committee. You're expected to be there, but and then to hear your partners who are back there reading films saying that, you know, I've been here reading films and you're off doing that or whatever. You know, for one that's involved in a lot of those committees and conferences, it's not like going outside the hospital to go have lunch or something like that. So I'm not sure who still got the better end of the deal there. So what we did was we identified 35 buckets of value, and I've published this in JACR, of all the extra things that we do. And what I did was, because I can't do this alone, and as chair of one of the hospitals, and we cover multiple hospitals, we tried to do, we followed Cotters' 8 steps. We're going to try something here at this hospital. And what I told my fellow colleagues is, I'm not going to say, you need to do this, you need to do this, you need to do this. Tell me what you're already doing, okay? That has nothing to do with reading a film. Let's just start with that. And then, and again, they had in their mind too that, look, we almost lost this contract. We lost a piece of our group. We may lose some more. So that's what I started with. And then the question came up is, okay, how do we let you know? So we started out with something very technologically savvy in 2012. Little pieces of paper like this in the reading room. And they had just little things that filled out that said who you were, what activity did you do, what date did you do it. And that's how we got started. I just told them, just tell me what you're doing. Long and short of it is and people understood the reason. We started it at one hospital at the end of 6 months to 12 months. So now this is around towards the end of 2012, beginning of 2013. I collated all the data. If you do that in your practice, you will be surprised at how much probably many of your members are actually doing some stuff, and I was very surprised. I collated it, year came up, presented it to the CEO of the hospital and the health system, and also several members, and I said, you know, does this meet the bill? And, you know, when they start writing notes down in your presentation, and there's a little bit of oh my God, sort of moment, that's when you know you've got them. The other thing that I did was I did not present it on myself. I had the chair of my radiology group and our group's chief administrative officer and the administrative head of the radiology department there too as an audience, because I did not want this to be me telling somebody something and then relaying it back to my group. Long and short of it is the CEO said, we never knew you were doing all of this stuff. Would you please present it to the medical executive committee within 2 weeks? And so I presented it to the medical executive committee of that hospital. The following year, we ended up doing it at all the rest of the hospitals, presented it to their respective medical executive committees, presented it to the boards of the hospitals too, because it was such a compelling story of all the investment that we were putting in. So what you can do as you go back, certainly I think documenting what you've done, presenting it is the real key, and try to do something different. I did do something different. I ended up doing lean healthcare training at the hospital. The only physician to ever do that. So then one would say is, what's the benefit? Yes, I did it on my vacation time. Yes, I did it on my other days off. Yes, I did it on my post-call days. But what was the benefit of me being in there with 50 other people who are now directors and managers throughout the entire healthcare system? I have a lot of good friends now because I was the only physician that did something different. And so when I want to talk to the head of surgery, the administrative head of surgery, the administrative head of pharmacy, I have those relationships now I never would have envisioned. And so that was sort of the turnaround. And in sort of the final chapter, I'll sort of talk about even the so-called icing on the cake.
Excellent. But before we move on to Dr. Calendine, I just want to offer the observation that you've just heard two stories of circumstances that were essentially existential crises for two well-established groups. And the strategy that was employed was tremendously different. In Dr. Webb's case, a confrontational strategy ultimately was what was successful in terms of getting the hospital to wake up and to recognize that, maybe it's better to collaborate. But sometimes confrontation is necessary, and clearly it had a big impact in their case. Whereas in Dr. Patel's case, it was really a matter of recognizing all the value that is being created and not being documented and communicating that effectively. And so in some respects, I'm sure these strategies were born out of the relationship that existed at that moment with the hospital leadership. In Dr. Patel's case, there was a hospital leadership that was clearly receptive to hearing a very reasoned and data-driven communication. Perhaps in Dr. Webb's case, the hospital leadership was a bit too far gone initially and really required the wake-up call of legislative action and risk in order to recognize that, hey, there's probably a better way. So, as you listen to these stories, even though, the circumstances overarching them have a lot of similarity, the local environments, the players involved dictate different strategies. Okay, Dr. Calendine.
So as we thought about strategies and way to engage the group, I think the first step was a brutal honesty about where we are. Everybody in this room knows the value of radiology, but that's not always as clear to the hospitals and even the clinicians that we work with. And so we spent some time talking about how we were viewed or what they saw the value is, and you have to allow some time to emote about what your value is and how you perceive it and how there's a difference. And then I think, importantly, we took a careful inventory of the assets that we have at hand. And I think this is where some radiologists leave something at the table. We are large groups, almost all of us. Probably most of you that are in this room come from a large group. And you have substantial assets at your disposal. We're multi-million-dollar companies. We have significant infrastructures. We do sit at the crossroads of many things in healthcare and medicine. And so you have to take a real close evaluation of your assets, but maybe think about how you could use them in a different way. We set out our goals. They were pretty clear. I think we came to a single strategy that addressed them all. That's not always the case, but that's where we came to. And our first goal was to gain additional leverage with the hospitals. And I don't want to mislead anyone to think that we had any real conflict with the hospitals. At that time, we had no real conflict with the hospitals. In fact, we had a very close relationship and continue to have a very close relationship with St. Thomas Health, as well as a community hospital and then another hospital that's owned by CHS. So much so that they want to expand services and have into some of the other areas and some of their other, as Ascension calls it, ministries. And so while we were in a good position in the spirit of good to great, we looked for those vulnerabilities and we never took our success, we never counted our success as stability. And so we wanted to gain additional leverage with the hospitals. We definitely wanted to gain some additional leverage and control with our clinical colleagues as they were going to sit at the junction of where payment models were going to go. With a patient-centered medical home, it's going to rest with the primary care docs with risk-based models and bundled payments. A lot of times it rests with the surgeons. And we were not willing to just see our future as a contracted service. And then we wanted to maintain the independent practice of medicine so that we maintain the imaging referrals. And this is a bit more granular, but no less real. In fact, more real, that if we saw all of these physicians employed by Vanderbilt or HCA, we would be at significant risk for where we were. So given that and given our concerns, the strategy that we put together was to significantly expand our radiology group, in fact, reach beyond radiology. So we set out on a course to form, and when I say form, I mean own and control a large multi-specialty group in Nashville, in Middle Tennessee. And so that required an infrastructure expansion that the partners had to be willing to invest in, and it required a particular attention to compliance. And so we hired and have and continue to have in-house counsel. But with the growth in infrastructure and expansion, of course, the partners had to be behind that investment that would really prepare us better for the future. And so that was the strategy, and we got good buy-in from the partners. Van talked earlier in the last session about how sometimes you go with an idea and then you kind of back off of it for a while and then you go back to it to try to get them involved. I like the boiling the frog analogy. I don't know why you boil frogs, but at any rate, the analogy is good. If you have a frog and you throw it into a boiling pot of water, it just hops right back out. But apparently this is true. I've never tried it. I'm not a sadistic. But if you put a frog in water and you slowly turn it up, it will just sit there until you boil it to death. So this is outside of PTSD. This is my second most important management strategy as it relates to the partners. Is I boil the frog slowly. So you have to sometimes go there, come back to it, and understand what frogs you want to boil.
Excellent. Thank you. Dr. Zaidi.
So we saw the circumstances happening, especially the younger partners, and in early 2010, a bunch of us were basically going to leave. We had a revolt inside the group that income was down. There was no feeling of real job security necessarily. I think the disparities in productivity and handling physician behavior, there was lack of engagement amongst many members of the group. And if your young people leave, then that's the death of the group, obviously. So we did have a revolt. I was elected president, and we had some younger members on the board. And then, we started looking around and said, okay, now what? What do we do? So we, and thankfully, basically the ACR was there, right? So, everything that our group has done and had success with in the last few years is a credit to the ACR. I always say this at every meeting. I'm a product of the ACR. I went to my first ACR practice leaders meeting in the fall of 2010, run by Larry Miroff, and it was quite eye-opening, that there are actually strategies out there that people have been talking about how to define your value, about how to engage with the hospital, about strategic planning. I didn't need to go and get an MBA to just teach basic common sense strategic planning, scenario planning strategies. So we took what we learned there. We actually brought in Larry Miroff to do strategic planning with us. That was very important because he has the gray hair to tell the other gray-haired people in the group, that, okay, we can change, we can move forward, and bring everyone together. I think it's important to bring an outsider in. Okay, you can never be a prophet within your own group. You have to bring someone with credibility and experience from the outside who can speak to the diverse members of the group and try to bring them together. We did do, he guided us through the SWOT analysis, and we did the internal strategic plan of looking at our weaknesses and changed our governance. So we adopted a central board for a group of 24 at that time, 5 members got elected, and centralized more of our governance. We were still doing partner votes for new contracts, although this year we evolved to even more central governance, and we don't even do that anymore. But at that time we were still doing that, but at least we got rid of people being involved in HR decisions. We adopted a service mentality that, it's just like what Andy DeLau said in the Morton lecture. Why are we here? Okay, we are here to serve patients. We're community leaders, and we should serve our patients, serve our customers. So we do have multiple customers, and you do have to be strategic about it, that, okay, your customers are your patients first, but then you have to cater to the referring physicians, the hospitals, the hospital consolidation, bigger systems where the CEO is somewhere that you don't even know where they are. The payers, ultimately, as well. So the radiologist had to say, this is not about me, this is about how do you serve your customers. Then an ownership mentality of fixing problems. Okay, if you call yourself a partner, or even if you're employed by the group, again, we're physicians, we should take ownership of making sure that if you can't read the case, then somebody else has to read the case. And we wrote that into our bylaws and our contracts. And then we said that, okay, we need to keep growing, basically. We need to be able to go to that hospital an hour away, a half an hour away, and we started to do that. And we did grow our contracts. We We also invested heavily in IT, and we did increase our productivity by about 20%. We did downsize a little bit, let some people retire, have a better balance of subspecialization, and then so after we did all that internal strategic planning stuff, get everyone on the same page, then we said, okay, how do we engage with our hospitals? And again, I took an idea which was talked about by Michael Brand-Zavatsky in 2011 at the ACRPL meeting of co-management, of how a private practice radiology group can engage with the hospital while maintaining its own private practice, not get employed, but come into alignment. And that was very important for us because we did not want to be seen just as a contracted group. We did a lengthy strategic planning process with them. It took a year of meeting with the CEO every month to go through what is the value of radiology. Not as well codified as what Samir said, but again, just took ideas from the ACR meetings, presented to him about what is the value of hospital-based radiologists, particularly versus the Telrac companies, IR services, and how we can invest in care coordination and decrease length of stay. And then, lucky for us also, I think, Dr. Rubin is right, that in our case, we were lucky that the hospital had done co-management with a private oncology group and with the employed cardiology group, so they were open to doing co-management with us, even though they hired a consultant to advise us on this, and the consultant had no idea, how do you enter into co-management with a radiology group. So we did have to innovate around that, and in the next section I'll talk about how we did that, how we established, and what kind of metrics we picked.
Super. Thank you. Dr. Breslau.
Thank you. I'd like to try to divide up the rest of my two parts into one kind of some of the conceptual things about what we looked at and how we tried to evaluate what was important in the future, how we survived, and then the second part a little more of how we actually accomplished a transaction at the hospital. So we initially, as I said, lost our hospital contract, and it was about 10% of our revenue. It was that low because we had a very large outpatient presence and a very large radiation oncology part of our practice that wasn't affected. But looking forward, you can see that it was the 10% was a starting point, and that there were some other kinds of contracts that were going to sundown eventually, and at some point that would be a much bigger number. In our healthcare marketplace of about 2 million people, there's very high consolidation. Most patients get their healthcare through one of four things: Sutter, Dignity Health, UC Davis, or Kaiser. And there isn't much kind of clear space. So one of the things that I started out doing shortly after the announcement that they were out, I became president of the practice, just like a couple of these other guys did. I think we all have the same thing. Everyone else was smart enough to step back, and we were checking our emails, so we didn't notice. So we were the president. Well, that's what happened to me anyway. But, and so one of the first things I set out was to try to go back to leadership of these major health systems. Well, apart from Kaiser, I didn't think that was really an option, but to go to the CEOs of Sutter Health and Dignity and so on, and basically say we believe our future is dependent upon the strength of our relationships with the health systems in our community. All of them know the physician base we have and the large geographically spread outpatient footprint that nobody else has. So we are bringing a known entity to the table. Anyway, so I started doing that. Internally, we kind of had an all-hands meeting, and everybody agreed to take and the diagnostic division agreed to take a little furlough and a little bit, we kind of just circled the wagons, and nobody left the practice at all, despite some of the initial recruiting efforts from Sutter. We moved forward. Also during that time, we talked to a couple different suitors, VC, private equity, and actually publicly traded imaging businesses, to talk about what that might be like if we entered into relationships with them. And none of that, all of them had pluses and minuses. staying within a health system in our community was the only one of those options that represented a permanent commitment to providing health care in Sacramento and the metro communities. And we have 60 doctors and over 800 employees, and I felt a personal responsibility to look after sort of the span of the pathways of the careers of these people. Anyway, as we were doing this, we were approached by the hospital, by Sutter, to do a total acquisition. And then, which I'll talk a little bit about in the third part. But I do want to mention a couple other things in terms of strategy. First of all, the burning platform was extremely important. That moment we're talking, things were fine, but the understanding that clearly what was going to happen in 3 to 5 years was ugly. And as I mentioned in the first section, we don't have a way of unwinding people's equity in a orderly way that doesn't kill everyone else. It's basically a rush for the exits. CMS is making plans that don't benefit us necessarily, that may benefit us in an integrated delivery network, like the goal of having 50% by 2018 of Medicare payments based on quality and value from within alternative payment models. And it's very hard for a single specialty group to do full-on ACO or whatever. So that's something I thought was very important to understand. And then we started on a bunch of new initiatives. We started a teleradiology venture of our own. We really expanded our own multi-specialty component of our practice that we felt was kind of moving upstream, and to help to kind of own the referral source for we had urology, medical oncology, vascular surgery. A lot of the referring doctors we were now employing. We had been doing that before, but we really ramped it up. But anyway, the end of this section, I just want to make the point, because I'll talk about it later, that we were then faced with the hospital system who had kicked us out, now wanting to buy our entire practice. And I'll talk about that in the third section.
Great. So just, in continuing on the theme, everybody has really taken different approaches and implemented different strategies to their circumstances. But one other thread that I heard consistently, number one, was that some of these rubrics that are out there, the ones I talked about at the beginning, whether it's Cotters 8 steps that Dr. Patel talked about, or a SWOT analysis that Dr. Webb talked about, actually are not just academic exercises. They're really tools that can be useful. And taking the time to look out for them and familiarize yourself can be very empowering. The other is the role of organized medicine coming in and helping out for these different folks, whether it's the AMA or whether it's the American College of Radiology in particular, which probably has had even a more profound impact across the board here. And to think about, in times of stress, there's a tendency to want to kind of hunker down and figure, God, I got to figure this thing out. But I guess a real important message here is to recognize that there are other people out there who can help you with your pain. There are external sources that will provide a light on the problem and that'll have a perspective that's going to be really empowering to you and really helpful. So in times like this, avoid the instinct to turn inward and to stress out with the group, but to reach out and to really see what resources are out there to help you. And then pay it forward. The concept of, oh my gosh, I can't believe these folks helped me. The notion that, we all are here to be able to learn from one another. And, there's no greater pleasure or privilege than having made mistakes and helping somebody learn from it and see them avoid it. So, I'd say that all of those are elements that I took away from the conversation. Let's turn to the very last part here, which is the implementing of change, and hear the kind of some of the final outcomes around these stories. Dr. Webb?
So, trying to get to some of the lessons learned and the outcomes. One of the lessons that we learned was that as a group, for various reasons, we had structural problems within the group, and that one of the structural problems had to do with ownership in the imaging centers, which was disproportionate, significantly so. And the because the imaging centers were seen and actually were a significant part of the irritation that Intermountain had with our group. It wasn't the only irritation, by the way, because groups were getting similar pressure with no imaging centers, but our group perceived it as a significant problem in our Intermountain relationship, and it was. And those with a minority or less than par ownership were particularly upset with the rancor, as you can understand. So one of the lessons learned is we needed to equalize everything in the group as rapidly as possible. We asked to meet with the CEO, we met with the COO of Intermountain Healthcare. Interestingly, the first comment was, we had no idea you guys were so upset. I'm not sure why that was, but that was the first comment. There was an agreement to enter into negotiations, and those started rapidly. The first meeting with the COO went very well. Intermountain named a negotiating team. Those negotiations went amazingly well until Intermountain fired that negotiating team and hired an attorney from outside of Intermountain to carry on the negotiations. And so, in essence, in a very short period of time, we had, I think, what we consider 2 trust bankruptcies. The hired attorney who was carrying out the negotiations was, I think, a straight shooter, fairly hard-nosed, but walked back almost all of the points that we had already discussed. We are now, several years later, just about ready, hopefully, to finish those negotiations. Okay? So this has been a multi-year process. It is not done. It hopefully will be done in the very near future. Our group is, once again, committed to alignment with Intermountain, and we have made that clear. We are committed to being equal within the group, so that we're internally aligned. Our group has decided, I think probably because of the, certainly as a factor, because of the 2 trust bankruptcies. Intermountain has changed faces, we've changed faces. I'm no longer on our group's board, and our group has a new board that does most of the acting with Intermountain Healthcare. I would say that we do see a future that entails alignment with our major healthcare system, and we also see a future, at least at this point, based on discussions that we've had both internally and with Intermountain, where we think we can best achieve that by remaining an independent group. We have been able to successfully negotiate a compensation model that is very different from our old compensation model, strict fee-for-service, our group doing our own billing. We hope that compensation model will facilitate alignment with the other groups that are within the system and help to break down walls for clinical exchange. Intermountain finally agreed that they would be willing to purchase our imaging centers as part of a way to minimize competition between our 2 entities, and that's part of our current discussions. I'm hopeful that brighter days are ahead.
Marvelous, marvelous. How about a round of applause for Dr. Webb? Dr. Patel?
So, thank you. So, once we sort of put out the fire, so to speak, and started to see the value that was now, so the questions were, how do we make it sustainable? How do we keep it sort of going? Because it can't be a one-person show. It has to be, the entire group has to buy in, and going forward too. So I would say the first thing that we did was, now that we had a platform for people in the group to demonstrate their value, what we did was we showcased that internally now. You know, I'm a fan of good stories. There's enough gloom and doom out there now. It's like, you know, let's try to smile every now and then. So now we have a pathway that internally we talk about, you know, hey, you know, this was a good thing that occurred. The other thing to get buy-in from the group members to sustain this going forward was we took the direct comments from the CEO of the health system, who said, you tell your group members, this is exactly what we wanted to see. And that is very powerful. And then also when I presented at the various medical executive committees, the various boards, it was not just me presenting. It was people from my group that was present there, so they could get a feel from the room and they can hear the comments from the respective leaders. I have the ACR to thank for many of the things. And one of the things being in private practice is I had the fortune, and my mentor was Valerie Jackson, and got me onto some things with the ACR from a volunteering standpoint. I cannot tell you how much value that brings to a private practice hospital when you tell them that, you know, hey, I'm on this committee for the ACR. Hey, I'm presenting at the ACR meeting to share a good story about your institution. That is pretty cool. And that has a lot of value, and I think we underreport or underestimate the value of some of that sacrifice and that investment. Now that we demonstrated the value, we actually kind of took back and went to the volume status. We showcased it to the hospital and said, you know, look, here's the other reason why we should be involved in pretty much any discussion that goes in the hospital. In most hospitals and health systems, radiology sees the second most number of patients, second only to one other entity, lab. Okay, so we see a lot of people. The other thing is from a single specialty contribution profit margin. Show me another single specialty profit margin that has a higher than radiology. So we bring in a lot of money to the health system. We see the second most number of patients, second only to lab. And now we've demonstrated the value. That's the story. And so we started with that. We also started doing some projects now that they can actually help partly meet the macro requirements and stuff too. One of the biggest cultural changes in our group was shifting now to a customer intimacy model. If the hospital wanted to do something and it involved imaging, tried to strongly tell the members, you know, the first word out of your mouth should not be no, okay, because you might have to maybe do something a little bit extra because you don't know the downstream ramifications. So one of the things that we did was a thoracic clinic and a thoracic lung screening program. We published this in JACR a couple of years ago. And the amount of notoriety, and believe me, when it came time to publishing around private practice, you know, we don't have dedicated time to publish things and things like that. And, you know, when it came time to me to writing it, because nobody else wanted to write it, you know, we did that, but then we had the hospital's name on there to showcase to the hospital that, you know, and we never thought any of this would happen, that, hey, we had a publication about our lung cancer screening program, and it was in your hospital. That really goes a long way as far as continuing to develop that trust. The RADs have bought into the Kool-Aid because they've heard it from the hospital, or beer, wine, whatever your choice of beverage might be. But they've bought in now because now they see that our clients, our hospitals and non-hospital partners really value this stuff. And such to the point now is many of them will call me or even text me or say, hey, is this considered value? And that's the only thing I always wanted. Okay, that's all I ever wanted, is to stir the conversation, because it can't rely on just me. It can't rely on just one individual. We do foster some other things to help continue to propagate this. If people in our group want to learn more about leadership, they will get extra CME dollar amounts, and our executive board has deemed that that's very important. So if somebody wants to do and go learn that, they will get more CME monies than anyone else. And then sort of the final thing to kind of close my story in this summary is going forward now, you know, this got me to the board of the hospital. It is a great position to be in. I've been able to share this story with non-physician board members. And so with non-physician board members, it's interesting. When you start out by, we see the second most number of patients with the highest profit margin. And many of these are business people. So it's instant. And then, so they understand, they have a better understanding of radiology. They can help spread the story. The hospital board absolutely loves our group, but then we present this annually. So it's not like what we did even last year or even the last 100 years is good enough. We continue to present this. I will be presenting this at the IT department in a couple weeks, because lo and behold, I'm not a very smart guy, how much we gripe about IT until I tell my partners, I think can you do this yourself? Can you maintain it yourself? Can you do this yourself? Maybe tone down the negativity a little bit, because at least the hospital bought this for us. How many of you guys paid for all this? Can I say show of hands? So to show this story with the IT department, the chief information officer said, would you be willing to share some of these things that you've presented to the board, to our IT people, to showcase that what they do on the front end impacts what happens in clinical care? They'd never been asked that before, okay? And then now we're also going to be presenting to our pathology department too. And so the story that we have is, tell what you're already doing, showcase it, develop a strategy, but we do a lot of stuff. And so it's great to tell the story. Thank you.
Thank you. Dr. Callandine.
Okay, so 2.5 years ago, we started out as 40 radiologists intent on becoming a multi-specialty group, and sort of lined up all of our ducks and went out and started with some of the referring clinicians that were closest to us clinically. And they were seeing a lot of the same challenges that many clinicians see: decreasing reimbursements, difficulty managing their practice and their infrastructure and overhead, difficulty with scale. And so we found what was a very receptive audience. And so we have, in the last 2.5 years, formed the largest multi-specialty group in Middle Tennessee, and the coverage area extends well beyond Nashville now, where we have 200 physicians. We have 100 mid-level providers. We have over 140 sites. The radiologists are the only shareholders. We own and control the group. The hospitals no longer have a strategy meeting without us, and I'm not talking about a radiology strategy meeting without us. They don't have any strategy meeting without us, which has its ups and downs. I spend half my time in hospital meetings now, so it does take up time. But we are on every strategic board and initiative that they have, because we have some of the largest referring groups in town. Oddly, and hopefully there's nobody here from, there's another large radiology group in Nashville, but their health system, I meet with them with almost the same regularity as I meet with St. Thomas. Not about radiology services, but about what our clinicians are doing and where they want to see them grow. In fact, HCA calls us to employ physicians on their campuses, knowing that we're going to suck out all of the imaging. But again, what hospitals remain focused on are inpatient admissions and surgeries. And so we're not going to move those around until we own a hospital, and then we'll move those around. HCA was very honest with us, and I do love this honesty. And Jonathan alluded to it just a minute ago. The hospital's view, most hospital administrators' view of a physician group, a large physician group, that even aligned, not employed, but aligned, is that they're like a pet rattlesnake. And so I love this analogy. So it is your pet. You do love it. You want to take care of it, but you're scared of it, that it's going to bite you. And so I don't mind being the pet rattlesnake for HCA. With St. Thomas, we're considerably more aligned. Hopefully they don't view us quite the same. But the difference between what we did and where Jonathan, because he can share with you that when they did that strategy, I think it worked against them. They were in a hostile environment. Getting the context, they were in a hostile environment at the time with their hospital that they wanted to be in alignment with. And as they hired referring docs, I think Sutter got more scared and more apprehensive. We did this in an environment where we were very much aligned with St. Thomas, and HCA had no leverage or control or say one way or the other. I didn't care if I pissed them off. I didn't care, either way. It wasn't my intent to do that, but I didn't care. So I think the same strategy under different contexts can have very different results. We are the hub of discussions for all the major payers now about risk-based models. I spend the other half of my time meeting with Cigna and Blues about that. We have a significant primary care presence, and so we're developing some novel risk-based approaches. And as you can imagine, in each of those, the radiologists are paid very well for their portion of the studies. Our outpatient imaging continues to grow. That was certainly a concern of ours. We now do over 250,000 exams a year. In our outpatient centers, we've grown to 14 centers. We do over 150 MRs a day in the outpatient centers, and we have 3 or 4 more centers slated for the next couple of years. And we continue to grow and diversify. We add additional clinicians every month. We rarely print the directory. We do have an app because a printed directory is out of date each month. So it's been a very effective strategy. It has changed our environment and perception in Nashville entirely. So if you know, I haven't heard of it other places. I haven't heard of other radiology groups doing it, but if it's applicable, I would pursue it.
Dr. Zaidi?
So we negotiated with the hospital for co-management, and like I said, they already had an existing structure, so at least we had sort of a boilerplate contract, but the strategy was that it should not be seen as a subsidy by the hospital, and it should not, or by the referring physician, because some people do say, well, co-management is just a path to employment, or you're just informally, subsidizing the physician group. We wanted to use it to drive culture change on both sides, right? So once our group adopted the values of having focus on customer service and an ownership mentality, that started to drive our strategies of how we would engage in alignment and co-management with the hospital. We wanted to put in a pay-for-performance system and sort of a 50-50 split between medical director fees and then metrics that were at-risk metrics. And we did not want to be just judged by turnaround time. Again, what is the value of radiologists? I think, even now when you look at some of the metrics out there, a lot of them are still process-based metrics. We wanted clinically meaningful metrics. And even though there aren't necessarily that many out there, I know the ACR is now still actively developing them in the Value-Based Payments Committee. We, at that time, this is 2012, when we were starting this process, we picked metrics that were meaningful, especially to our customers. So we took some customer complaints from the referring physicians in particular, or what we ourselves saw as issues with patient care, and turned them into metrics, right? So one example is CT biopsy accuracy. Our oncologists were saying that some of your radiologists aren't doing core biopsies, some of them are not getting enough sample for tumor markers, the biopsies are inadequate. So you make a metric out of it, and you write it into a formal shared governance structure of co-management, and you drive the culture change on both sides of the radiology department, what the radiologists have to do, and in this case, the department didn't have to do too much, but basically it was the radiologist turning an eye on ourselves. And I think that principle follows through, that if you don't run from your complaints, I think a lot of the private practice groups just try to gloss things over, or the job of the president is simply to whitewash what's happening in the group, okay? And they expect me to go to the hospital and justify, sort of subpar patient care. I mean, I don't think anyone should do that, okay? So you want to use your political capital that you've built up with people like Samir, who's on his, I don't know if you mentioned that, on his hospital board. I mean, he should not be defending his group, sort of bad behavior to the hospital, okay? So we made a metric out of it, and ultimately one interventionalist had to stop doing biopsies because he was basically the problem, that he didn't feel comfortable doing cores. And ultimately he retired. Okay, so the governance had to be such that we were not going to run from that issue. You had to attack it. And so we made other metrics out of things like IVC filter retrieval. We owned that issue of saying that yes, interventionalists, if you put in a filter, we should follow it up. And we increased the retrieval. And now all over Ohio, all I see are ads by lawyers about IVC filters, and whether it's been retrieved or not. So we've had that process in place for years. Mammography recall rate, We had an insurer at the table. Our hospital owns an insurance company. They were willing to pay us an incentive to have a recall rate less than 10%. And the mammographers, I mean, I don't know anything about mammography, but basically they agreed that that was an appropriate thing to do. And how did they do it? Some people had to stop reading mammography. Only the best mammographers were reading them. And again, you had to tell some physicians and hurt their egos that, you know what, you're not going to read memos anymore. But if you're focused on service and ownership of your problems, of fixing problems, then you have to act that way. And we were very successful in co-management with the hospital. Now we are working with the hospital-owned payer. We have a contract to do utilization management with them. We are educating referring physicians about appropriate utilization. And we are now being advocated by the hospital to the other area hospitals, helping us grow, basically telling their friends at the other hospitals. And we've picked up a couple of extra hospital contracts that way. So it's been very successful, and you keep the process going by keeping everyone engaged and turning your complaints, you know, rather than running away from them or hiding them, you turn them into an action plan and follow through. And as you pick up steam, then you attack more and more, more and more difficult issues. And I think that's the takeaway point, that use your leadership and your political capital to actually fix your problems and ingrain it into the governance of the group. Thank you.
Bravo, Dr. Breslau. If maybe hold the mic a little closer as you speak.
Great. So I want to talk a little bit about our process of getting from a sort of surprise offer to have our practice acquired by the health system that had just tried to kill us, to the point that we had consummated a deal. As I had mentioned, the board is everybody, 60 people on the board. And so it required an obsessive level of transparency and patience. The very, very first thing we did, we went around to every single person and got them to sign non-disclosure agreements, and then we started talking about it. And we had to go through, you know, all the deal terms, what salary, time off, that kind of stuff for the doctors. We had to go through, there's 3 documents, the covenant not to compete, and then finally the asset purchase agreement. And the initial perspective on a lot of people was, well, you know, we'll look at it, but this is never going to work out. I think I'd say that probably 50% of the radiologists felt that way at the beginning. And also, I think the biggest kind of disparity, the biggest range of opinions was about the purchase price for the assets. Everybody's heard a story about this or a story about that, and some ophthalmology practice that sold for a 10 multiple and various kinds of things that really didn't help. But what really was essential was to kind of take all the input seriously and kind of independently investigate everything, all the comments that came in. And you know, the initial thought in my head many times was, that's stupid, but didn't say that. So we're like, great, let's look into that. Let's find out about that. And then a couple other things, you know, culturally in my practice, especially the people on the executive committee, which was a subset, one of the things that people on the executive committee really loved to do was be armchair corporate attorneys, armchair investment bankers, you name it. And they believed that to be very high-level advice that they made up off the top of their head with no experience whatsoever. And that was part of their fun of being on the executive committee. So I knew that was not going to help us. So I brought in, very quickly, we engaged very high-level expertise in those areas. We went to a valuation firm based in Dallas that does, if Sutter was going to value something, a big practice, this is the type of firm that they would engage. And we had them on our own. We paid them to do a valuation of our practice first, just so we had it in our hands and we could look at it. And then we brought in a very specialized healthcare attorney from Los Angeles, who his entire practice is healthcare M&A. And He also has written books on START compliance. He teaches attorneys about START compliance. So what that helped, so those two things really pushed the process forward because people inside our practice had trust that there was, things were going the right way. Again, the valuation thing, we were able to then hand it to Sutter and say, here, and they, after we had already looked at it, we were able to hand it to Sutter, and they basically agreed to start with that. There were some modifications, but that was the final purchase price was heavily anchored by what we had engaged the valuation firm to do in the first place. The healthcare attorney was incredibly important because Sutter's relation with doctor practices is they have attorneys, and they're used to dictating terms. And we had always had this kind of mistrust or bad taste in our mouth, and so we needed to have somebody that was at the same level or higher, and actually in many cases he knew more about the information than Sutter's attorneys. And so they're used to saying, well, that's a very nice idea, but we can't do that, that's not in compliance with START. And he would say, yes it is. And that kind of thing slowly really got us to a point where we could accept or reject things, we understood what we were doing, and then at some of the things that were a little more impalatable, Sutter was forced to just say, well, we know there's no reason, but we just feel like doing it that way. So at least it's out in the open, right? And mainly the big process was transparent communication and extremely careful planning of meetings. So if we knew we had to have documents approved by the doctors, the month before that, we would send it before the meeting to everybody to read. And at the meeting, we would go through it, and plan on not voting at that meeting, because then give people a whole month and say, we're going to vote on this next month. And so knowing that you're going to, so that the emotional, the yelling and screaming, the I'm going to sue you, I'm going to sue you, is before actually having to vote, a month before actually, because it does happen, actually, you know. And so that really helped a lot too. So the actual voting moments, the decision points were relatively unemotional. And then finally, I realize I think I'm going over. I just want to say a couple words. So we ended up with a very, very good salary that was close to what we had, the same time off that we had in private practice, and stability in a tumultuous era in healthcare. I also think that it's very exciting right now being inside an integrated delivery network. First of all, we're employees of a multi-specialty medical group. Organizing processes of care is kind of our day-to-day process that we have to think about. We've now done some bonuses that are tied to efforts on variation reduction for the radiologists. And then most recently, we've started a program coordinating imaging standards across the entire health system, which is the size of about 2.8 million exams a year. We're now starting a coordination at the whole health system level, which is also very fun and exciting, and really wouldn't have gotten off the ground without us initially being part of the health system. So thank you very much.
So before we open this up to discussion, I'd like to add a few observations. And the first one is that, boy, I'm not sure where that's coming from. Guys, check yeah, that's perfect. The first one is that, again, while there's diversity in the stories, to a person up here, there was hard leadership involved in getting to where they are today. And every one of these folks, representing a large group of individuals, took a major responsibility on their behalf and carried the organization forward to a place of stability that in some instances is even better than the past, and others is at least as good. But at the end of the day, they have all established a framework and a pathway for continued success. And that I'm sure that when I say this, every one of them will instantly flash back to the fact that there were sleepless nights, there were feelings of ulcers in your stomach. I mean, there were dark days in this, but you know, the consistent thread is that no one here gave up. You know, they consistently powered through. And that's what leadership is about, is making sure that you are delivering your responsibility for the folks that you are leading. And so I'm just so tremendously impressed with all of these folks in terms of what they have accomplished. I also want to point out to you that as you listen, you hear that they have evolved ongoing strategies, that they have defined a focus for what is best in their environment, whether it's building a big multi-specialty organization, as Dr. Callandine described, whether it's carrying forward to really establish the value of everything that is done by the group, as Dr. Patel has talked about. Every one of these folks has figured out what it takes to not only align for today, but to continue to nurture that alignment and carry it forward. And if everybody sort of rewinds back 5 years or 7 years and says to themselves, gee, maybe we didn't have very much strategy, I can stand here today and say every one of you have tremendous strategy at this point. And I want to point out to you that, out there in business with multiple organizations, people talk about the principle of competitive advantage. What is it about our organization that helps us succeed while others might fail? And don't underestimate leadership as an important competitive advantage, because for every one of these organizations that are represented here, there is now a competitive advantage that is built in due to the leadership that is now present, that will be patterned for others in the practice, and that is respected in the community. So that is in and of itself a very strong competitive advantage. And the final point I'll make is that a number of people ask me, I recently took some time to go to business school and earn an MBA, and people will say, wow, should I get an MBA? Is that important in order to do, this kind of work, to lead in this environment? Look at these folks here. The answer is clearly no, you don't need that. The skill and expertise to be able to take on these tasks resides in all of you. And you are all smart and resourceful people who can find ways to get the information that you need. And it's perhaps unfortunate that medical school doesn't contain a little bit more of the kind of information that helps us to know how to lead organizations, how to participate in organizations, how to achieve alignment, how to manage through change. But the good news is that lifelong learning is something to be embraced. It is something that is easily achieved and is demonstrated here in the stories and in the ongoing leadership of these 5 individuals. So if we could have one more round of applause for all these folks. And if there's any questions, the microphone is open.
Hi. One question I have for you is, in our practice, we're dealing with burnout as kind of increasingly becoming an important thing that we have to deal with. And I'm just wondering what strategies have any of you employed in your own practices for managing burnout?
So I think I'll just start. And yeah, all of this does come at a cost. And you're right, burnout is... the one key question is I think for us, what helped, and again, I'll put on my lean stuff, is what was the root cause of the burnouts? And are you hearing a consistent story as far as, is it hours? Is it, mental stress? Is it not feeling recognition? Is it not? So I think that is the real case, because burnout has many different etiologies. So I would say, start out by doing that. And the other thing that I tried to do to help alleviate some of that is always try to keep telling good stories and stuff, and the value of what people are doing. And yes, sometimes, it is a sacrifice. Yes, I would only love to work 3 hours a day and then go home and spend the rest of my time. But it will come as sacrifice, but then there's a lot of benefits. And I think sometimes it's perspective that also helps too. But a root cause to try to find exactly what caused that.
I think for our group, we were 24-man group. I mean, now we're about 20 radiologists with actually more hospital contracts. Because partly, again, as Samir said, sometimes the burnout is just sort of a lack of engagement or feeling of disparities. So first, we sort of optimized productivity. We invested in IT to be able to do that, but also governance. Like I said, that make sure that everyone feels like they're working to their capacity, as long as nobody feels overworked. There's going to be some differences in productivity, but everyone feels like we're pulling our weight. That's sort of the standard. We do have a minimum productivity standard in our group. So that way it prevents burnout from people being overworked. Also, we used to do, we used to all share in Nighthawk 3 weeks a year. And some of the younger members of the group coming out now, they don't want to do that. They want to be more subspecialized. The interventionalist doesn't want to do Nighthawk. So we hired one Nighthawk person last year to do 26 weeks. And that helps with, I think, a feeling of job satisfaction and burnout. You hire the right people and you put them in the right position. Not everyone can do everything. So the group needs to understand that, okay, the high producer who can easily read some of those cross-sectional MRIs, they'll get paid the same as someone like me and others in our group who are doing the leadership, the committees, the negotiations of the contracts. And as long as the group understands that, then you manage the different types of work. So I think it can be different for each group. I think it is a matter of listening, like Samir said, what are the actual issues? Is it job satisfaction? Is it just a feeling of overwork? And then you adapt the best you can.
Yeah, and I just want to say a couple of things. I think those are all good points. That the sort of the radiology production environment really should be viewed as kind of a psychology lab. And there are a lot of things that happen that you can really actively make the environment worse and ruin people's enjoyment of the job, and then make changes and they do the same amount of work and they like the job. And so I think the sense of fairness and transparency, that the sort of, not the RVUs, but the level of effort during the day is equal across different people, so is very important, and people have to trust that. I think that seeing a discrete amount of work that then you're done, that you can see completion. When we first came into the existing group within Sutter Health, they had their entire operation was on one work list. So no one ever saw the list empty. So they would get to work and there was 1,000 unread studies and they would do whatever they did, and at the end of the day there was 1,000 unread studies. So it was an exercise in futility. And again, you can read various psychology textbooks to find out that's a bad idea. And so we threw that away. At the same time they were getting reports about RVUs every day. So no one would read certain studies. They just wouldn't touch them because they were low RVUs and they took time. They just wouldn't read them. It'd go for a long time. So it was a bad psych experiment. So I think that the burnout is the core of it is what people spend their hours doing during the day, that they feel satisfied, they feel they are doing good health care, they're feeling accomplished, and that it's fair. I think that's the most corrosive of all, the sense that it's not fair.
Any other questions?
I guess I have a quick one for Dr. Patel. So you've measured the amount of value activities that your group does over a period of years. Has just the process of measuring that and showing the value of that to your administration, has that increased over time, or is it staying relatively stable?
So that's a great point. After we started, the question is what have you done for me lately? What about the last several years? And we actually do track that now internally. So last year our group put in about 11,788 hours, and we can line item it by whichever location, whichever activity, and those sorts of things. There was really minimal investment. I mean, the hardest part was conceptualizing all of this and putting it into a framework. That probably took the longest. Now, actually, as director of the program, I probably spend about just maybe 5 hours a month just looking at all the entries that are put in, and now we have a QA/QC process. The other thing that we've done now is now it's just no longer me. We've taken it to one of our committees in our group internally, so now they kind of manage a lot of that to get more people engaged. So now it's no longer just, oh, what's Patel think, or what's, so we try to get a little bit more transparent on that. But it was minimal investment. Our biggest investment was, we developed an app just to input this device, just not commercially available, but just a very tiny investment. Anybody can duplicate it. And we have an administrative person that can tally some of this stuff, and Microsoft Excel spreadsheet. That's the genius. Microsoft Office.
All right. Well, I want to thank the audience for your attention and participation, and once again, the entire panel. I think it's been a great session, and we've learned a lot from you all. So enjoy the rest of the meeting. Thanks, everybody, very much.